Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guests are Dr. Rebecca Keller, a heart researcher from Albany Medical College, and heart disease survivor and American Heart Association spokesperson, Michele Kieselstein. Welcome to the show.
Thank you.
Thank you.
Rebecca, why don't you talk about your work?
My work at Albany Medical College, I'm an assistant professor doing work on basic heart research. I'm interested in how the heart grows abnormally and also how the heart fails, as Michele will tell you about her story. Most of my research is, as I said, basic science. We use cell culture cells, cardiac cells, to look at the mechanisms of how they grow abnormally. We look at some of the clinical syndromes, clinical markers, such as fetal gene program that is increased during clinical signs and symptoms, clinical abnormalities of cardiac disease, and those are also reproduced in the cardiac cell in cell culture. We also use models of heart disease in order to understand better how heart disease progresses. So normally when a person is stressed, when their hearts are stressed, they go through an abnormal growth procedure. So their hearts grow abnormally. And then over time, the heart fails. And so my researcher is interested in how that happens. What is the progression from hypertrophy or abnormal growth to heart failure? If we can understand how that happens, then hopefully we can prevent heart failure, keep people in an abnormal growth process, because that seems to maintain cardiac function throughout the body. So if we can stop the progression, we can hopefully stop people from having heart failure, needing heart transplant, needing pharmaceuticals to treat their heart disease.
Now you have funding, you received funding from the American Heart Association?
Correct. Okay. In 2003, I believe, I received a scientist development grant from the American Heart Association. That grant enables junior faculty, so this is my first faculty position, it allows junior faculty to really increase their research funds in order to do the research that's of interest to them. I applied to the National American Heart Association and was granted that funding. And unfortunately, it did just end in December of 2006, but I'm hoping to apply for other American Heart funding and to be successful at that. The American Heart Association also gives funding on a local or regional level, which scientists at Albany Med and throughout the Capital Region do apply for.
And do you want to talk about what you teach to the medical students at Albany Medical College?
I teach clinical symptoms and syndromes of hypertension to the medical students, and that's taught in their first year of cardiovascular disease in the spring of their first year. And then I also teach pharmacology to the nurse anesthetists and to the physician assistants to try to have them understand how to treat heart disease, whether it be angina, high cholesterol, ischemic heart disease, or other types of pharmaceuticals that you might need.
And you have a PhD
I have
in physiology and pharmacology?
Correct. Correct.
To get those terms right.
Right.
Physiology and pharmacology.
Yes, I did my PhD degree at the University of Missouri in Columbia, Missouri. Okay. And my research project there was also dealing with heart disease, but it was dealing with heart disease in terms of septic shock. So when a person has a inflammation disease, their hearts can also be damaged. So I was trying to understand the mechanisms for how that happens. And then from there I did postdoctoral fellowships at the University of Illinois Chicago with John Solero, working on the actual contractile unit of the heart and how that affects heart disease and what those proteins are. And from there, I went and did a postdoctoral fellowship at the Mayo Clinic in Scottsdale, Arizona, to learn more about membrane proteins on the heart cell and how that implicates and helps progress heart disease.
It's very interesting. So today we are talking about women and heart disease.
That is right.
Let's just talk about maybe define heart disease, just so people understand what conditions fall under that umbrella.
Great. So heart disease is more of a syndrome. It's called a heart disease, but it's more of a syndrome that looks at how your heart functions. Typically, your heart has to beat so many times a minute in order to allow blood flow through the body for the metabolic needs of your body. So if you want to go out and run, your heart has to beat faster. If you're just sitting or when you're digesting food, your heart has to have blood flow to your stomach to digest that food, to again allow the nutrients to go around your body. So heart disease is when your heart doesn't pump as well. So it cannot maintain normal blood flow to all of your organs, your skeletal muscle, in order for you to be able to do what you want to do on a daily basis. This encompasses coronary artery disease, mitral valve problems, congenital problems. So there are some children that are born with cardiac abnormalities and they succumb to heart disease. Anything that allows your heart not to function as well will be classified under heart disease.
Okay. Now, the next thing we want to talk about is numbers. And you gave me some printouts from womenheart.org, which
Correct.
had some pretty amazing numbers there that really make it seem like women have to really take charge of their health, and women are at risk for heart disease, especially women that are African American and also Hispanic, correct?
Correct.
Okay, so let's run some of these numbers.
Right. So one of the misnomers of heart disease is that men are the only ones at risk for heart disease. And in fact, there are 8 million women in America that have heart disease currently. And that's a staggering number. And even more than that, 13% of women above the age of 45 have had a heart attack. And so one of the other misnomers is that heart disease is only for the elderly women or elderly men, people who are over the age of 70 or 80. But in fact, women who are in the prime of their life are coming down with coronary artery disease, having heart attacks. While cancer is the number 2 killer of Americans, it's actually known that 6 times more women die of heart disease than die of breast cancer. And that's a very staggering figure. I don't think that a lot of women understand this implication and that they understand that they need to take more care of themselves. They're so used to caring for others that they're not aware of the numbers and that heart disease is the number 1 disease for women.
Right. And they're saying 25% of women over the age of 65 have heart disease.
Correct.
And it kills 32% of American women.
Correct.
Now, there's also some at-risk numbers as well. One of the things it says here, if you don't mind me reading, the age-adjusted rate of heart disease for African American women is 72% higher than for white. Women who smoke risk having a heart attack 19 years earlier than non-smoking women. And women with diabetes are 2 to 3 times more likely to have heart attacks.
That is correct. And especially African American women, African American persons have a higher rate of diabetes, as well as they're more prone to hypertension. So hypertension is also a risk factor for heart disease as well. So African American women really need to pay attention to their risk factors as they are at greater risk than Caucasian women.
Right. Okay, and that actually leads us into the next part that we're talking about, which is risk factors. What are the risk factors?
So the risk factors are the same for men and women. And in fact, in 2007, just recently in February and March, 2 studies came out that improved on the risk factors of what clinicians look for as far as predictions for women. So some of the most common are age, smoking, diabetes, cholesterol, and so this is cholesterol broken up into the LDLs, which are your low cholesterols, and the HDLs, which are your good cholesterols. So you need to know your numbers for not only your total cholesterol, but how that is categorized between the LDLs and the HDLs. And then just recently, along with those risk factors, there's a new Reynolds risk score that was published in March of 2007 that adds whether you have a parent, specifically a mother, who had a heart attack before the age of 60. That is a new risk factor for women. And also there's a controversial risk factor called C-reactive protein, or CRP. CRP levels are normally higher in African American women than in Caucasian women, and there have been studies that have shown that CRP is a risk factor, and studies that have shown that CRP is not a risk factor. So depending on what comes out in the near future, as far as clinical studies, CRP may or may not be taken away from the risk factor list for women. Another study that was published in Circulation
Circulation is a medical journal.
Circulation is a medical journal. In 2007, also in February, also defined other risk factors such as a waist size above 35, diabetes again, physical inactivity, obesity. And so there's just a lot of these other risk factors that play a part in specifically women, as 1 in 2 women will probably develop some sort of heart disease within their lifetime. So with these addition of risk factors, metabolic syndrome, which is becoming a known risk. How well do you metabolize your food? There are certain enzymes within your body that genetically you're just born with, that you just have. You're either a high metabolizer or a low metabolizer. Exercise. Are you sedentary? Do you exercise a lot? So that's also going to be a risk factor. And in this particular study, they deemed that if you had 1 or more of those risk factors, then you were deemed at risk for heart disease. It used to be that you had to have more than 1 risk factor to be labeled at risk or high risk. With this new study, they're saying 1 of these risk factors could put you at risk for heart disease. This is for women who aren't already diagnosed with heart disease.
And I think one of the other ones they mentioned was poor diet.
That is correct. So it's very important that we get our vegetables, our fruits, our high fibers, and to really watch the fatty foods that we eat, the type of fats that we eat, so that we maintain a good balanced diet.
Okay. Now, the next thing we want to talk about is signs and symptoms. So, symptoms of a heart attack or symptoms of heart disease, how do you know that you're having a problem?
Typically, it's considered that if you have chest pain, that's what they deem as being a symptom of heart disease. Unfortunately, that's more for men. Men do feel that tightness in their chest. They feel that chest pain. It's not like a Hollywood heart attack where we grip our hearts and fall down. Also sweating, pain in 1 or both of the arms. Those are typical symptoms of a heart attack or heart disease. Women normally have atypical symptoms. These symptoms, even though we call them atypical, they're actually very common for women. And these can be back pain, neck pain, jaw pain, nausea, vomiting, indigestion, weakness, fatigue, lightheadedness. That's right. It doesn't sound like a heart attack at all.
No.
But these are definite symptoms that they've tracked over time, and these symptoms can occur between 1 week before you have a heart attack or even 4 to 6 months before you have a heart attack. And so it's something that women need to pay attention to if they have this pain chronically. So if every day they're having back pain or neck pain, if they're fatigued constantly, if they feel nauseated or if they have vomiting, these are symptoms that women more likely have as opposed to men. And I think that women need to pay attention to those, go to their physician, and just check out to make sure that heart disease is not something that is coming upon them. The doctors can talk to, the physicians can talk to the patients about their diet, about their exercise. They can order tests to make sure that their hearts are in normal condition.
Right, and I think that's part of how I think a woman can be her own advocate. If she doesn't feel that her doctor is doing the right tests, ask for it.
That's right. We are our own advocates as well as our families. And so if you feel that you're not getting the appropriate tests being taken, you can always ask for a second opinion or have someone come with you to really underscore what is happening, that this is a change in how you used to be, and that something is definitely wrong. Women tend to be caregivers, and we tend to care about all others and not enough about ourselves. And I think that with the research that women are very at risk for heart disease, that we do need to pay attention to our bodies and go to the physicians, go for our yearly checkups or more in order to have the doctors look at our hearts, make sure that it's functioning appropriately.
Okay. Michelle,
Yeah.
it's your turn.
Okay.
You have quite an amazing story, and I must say that when I talked to you on the phone, I had goosebumps and had to tell my coworkers and my family what's happened to you so far.
Thank you. Thank you. I appreciate it.
So, where do we begin?
Well, we can begin 15 years ago when I first started my heart disease journey. I was 32 years old, and I was feeling some discomfort in this area that was sort of consistent, and exhaustion.
Like muscle pain or bone pain?
Yeah, I walked on the treadmill or at the track, and I would feel this kind of muscle pain, gnawing, kind of feeling achy, not a sharp pain, but a more gnawing kind of pain. And I then started to, I felt complete exhaustion, and I started to cough, and I thought that, I must have some sort of chest congestion. And so I went to my internist, and he gave me antibiotics, and I went home. And by that night, I couldn't lie back because I couldn't breathe. And I thought, I took the pill, I did what he said, and it wasn't working. So I went back to him the next day, and he said to me, and he just didn't know that it was heart disease. I remember him saying to me that, well, it can be two things. You either have bronchitis, and it's certainly not heart disease at 32. So I went home, and he got me an appointment to see, to get some x-rays of my heart, which was very enlarged, and he sent me then on for further tests. And as it turned out, I ended up in the hospital in the intensive care unit, and I had an angiogram for the first time. And are you familiar with angiogram?
Can you just describe that for the viewers?
Sure. Would you like to do that?
Well, you had the procedure. I'll pull in when
You as the patient, from the patient perspective.
Yes.
You lay down on a table, and something like a long tube with a little camera at the end of it is inserted into your groin, and the tube goes all the way up, and then the image is on a screen, and the doctors can see everything going on inside of your cardiac life.
Okay.
Okay. So I chose to be out at that time. When I woke up, I was told that 2 of my arteries were completely blocked
Oh, boy.
and that I needed a double bypass immediately. And so the next day I was transferred, and at the time I didn't live around here. So I was transferred into Manhattan, and I was given my first open heart surgery, a double bypass. In the following years, I went along and everything was fine, and all of a sudden I started to feel a very gradual kind of exhaustion, but a sudden kind of gnawing back again in my shoulders.
Oh, boy.
So I felt the same symptoms come upon me, and I realized I better, let them know. I was having checkups like every 6 months, but this was within that 6-month time. So I went back, and the doctor said that in the angiogram, they could place a stent, that if they found something that was closed, they could open it with a stent, which is a little...
It's a wire mesh that they put into an artery to keep it open. Yeah.
Yeah, just to
It's
keep
just,
it open.
just to keep it open.
So I had a stent put in at the time, and the doctor felt very confident that I would be fine and go along, and he said he saw that everything was fine with my bypass, the 2 arteries that were bypassed. This was a different location in one of those arteries, just a tiny little spot, but this caused me all that tiny little spot. So a few weeks later, I started to feel the same symptoms again. And I went back through the whole procedure, and it started this cycle of going through having a stent put in with an angiogram and angioplasty, and so I had it done 8 times. During that time period, my doctor started to petition the FDA to see if I could get a coated stent. The coated stents are medically coated, and at that time they were being used in other countries, but not yet approved of in the United States.
So, Rebecca, can you talk about the difference between a regular stent and a medically coated one?
Right. And
I really don't know the difference between them.
So this has been years of research, basic
Yes.
research that's been funded from the American Heart Association, that allowed researchers to understand that when you put in a metal mesh, a wire mesh, the stent into an artery, what can sometimes happen is restenosis. So the artery can now grow, and you don't have a plaque that's going to clog the artery, but you have outgrowth of the artery, so it narrows the lumen so that the blood can't come through. What happens with the coated stents is that it elutes a drug to really inhibit that restenosis and to try to inhibit that growth, so it keeps the arteries open longer.
So somehow the drug is always
Not
present.
always. It's an infinite or a finite time that drug is there. They only have so much drug coated on the stent. The drug is going to elute, and at some point you are going to have the bare stent just left there. But it's the hope that enough of that drug has eluted to stop the progression of outgrowth into the lumen of the artery, so that the artery stays open.
Okay, so this had been done in
So
other
this was-
countries, in Europe?
This
did
was
you
done
say?
in other countries,
Okay.
implanted into other people in other countries, and not yet in the United States. And then after my 8th angioplasty and stent, my doctor got the okay,
Oh, my goodness.
and I did yet again experience the same symptoms. And so he brought me back in, and I had the new coated stent put in.
That was 6
And
years ago?
That was 6 years ago.
Okay.
And then while I was on, apparently the procedure went well, and I was in the recovery room, and I suffered a heart attack. And so I was in the hospital for quite a while.
Now, how
and
did that feel?
Very scary, very scary. Probably one of my more scarier experiences that I remember, because I hadn't woken up from the procedure yet, and I remember as I was waking up, the doctor and the nurse being on top of me, and literally, like, you see them slapping the person.
Slapping your face?
They were slapping my face and calling my name, and I could open my eyes. I remember opening my eyes, and then I could feel my eyes roll back, and I heard his voice getting louder and screaming more at everyone around. And then when I must have blacked out at that point. I don't remember anything. And then I woke up in intensive care, and it was quite some time later.
No
so.
white light.
No, I didn't talk to Elvis or anyone.
Oh my gosh.
After that, I went along fine for a while, and all along I knew when they go in with an angiogram, you can tell how your valves are doing, and I knew that my aortic valve had been leaking and the progression was getting worse. And so 4 years ago, I again was in really bad shape, and they're kind of, waiting until what was thought to be by the doctors the right time to go and do this, to actually remove my valve and put in a mechanical valve. And so 4 years ago I had that done, and I had a lot of unique complications afterwards, which led to really a 3-year time frame for me of not feeling well, and everything sort of wrapped around, and having had the surgery, which I came out of and just then needed to get better from. So it took a long time, but once I finished feeling bad, that's the way I think of it, and I started to feel good, I started to volunteer with the Heart Association, because I just always felt that if I got the chance, I wanted to do it. And so I'm happy to say that I am now volunteering.
So how do you feel today?
I take care of myself. When I can't do more, I don't. When I don't push myself too hard. Every few days I just will relax and rest, and otherwise I lead a completely normal life. I exercise 4 or 5 times a week. I take yoga. I believe in yoga strongly. It's helped me with my breath, and just stretching, and just helped me a lot physically.
And I would imagine state of mind too.
Very much
Mentally.
so. Yes. And I've got a husband and a son and family, and I can enjoy my time with them, and it's great. So.
Do you want to talk about how you celebrate your birthdays?
Sure. I celebrate my birthdays very happily. Everyone around me gets to celebrate too, gets their own presents, and sometimes it lasts as long as a month. So that's the joke about me.
And you reached number 47
Yes, I
this
did.
year.
Yes.
Fabulous.
Thank you.
So any advice for women out there, maybe that have gone through
Absolutely.
the same thing as you?
Sure. I went to Lobby Day for the American Heart Association, and I met women from across the country who have stories that are similar to mine, or different from mine, but nonetheless dramatic and difficult to get through. And I was quite moved by the stories that I heard when I was at Lobby Day. I also learned that 90% of doctors in our country, internists, do not know that heart disease is the #1 killer of women. Even
So
now.
you've got to meet them and tell them when you meet them,
Yes.
just to remind them.
Yeah.
And do you want to talk about your job as a spokesperson?
Absolutely. I love being a spokesperson for the Heart Association. I've been doing appearances all over and trying to promote women's heart health. We have our big Go Red for Women luncheon. This will probably air just after it, but we have our heart walk in October, and we light Nipper Red for Go Red Day and in February. And throughout the year, we have great celebrations everywhere for Go Red for Women. It's a constant movement that we want women to recognize when another woman is wearing red, it's a symbol for heart health and women's heart health. And so I
So you're
stand
wearing
for
red
women's
today.
heart health, yes.
How often do you wear it?
Very often. Actually, if you saw my closet, you would now see an entire section. Rather than slacks, there are red sweaters. So.
Well, you do a great service for the
Thank you.
American Heart Association.
They have done much more than I could ever give back for me and for many of us, and it's a privilege and an honor to be able to do it. So I'm very grateful.
Okay. Do either of you want to talk about symptoms that are not caught in the clinical arena?
Well,
How often does it happen, do you think, that someone is describing symptoms of a problem and it's maybe, I don't want to say ignored, but
I would say that it's probably caught, or it probably is not caught very often. It's probably missed. As Michele said, she was 32. They didn't even consider heart disease. And I think that for women who are young, that physicians are probably more keyed into the breast cancer, to pancreatic cancer, colon cancers, that may be more what's happening to women. Or, as we all know, as we mentioned earlier, women are caregivers. And so when you go into the doctor saying that you're fatigued, or that, you know, you're losing some sleep, that you might have some pain, that it might be because of your day-to-day activities. What have you done, started to do more now than you did that might contribute to those? And of course, that's very important for physicians to do. They have to look at all of the signs and symptoms and not just jump to heart disease. We don't want everyone to think that if they have back pain that they have heart disease. But it's a culmination of all the symptoms together, and just knowing that this isn't the way life used to be, that this is something new over the past 4 months, over the past week, that you've just noticed. Like Michele, she noticed this back pain, this neck pain that was kind of muscular.
Yes.
So what is that? What could that be? And so while heart disease you shouldn't automatically put someone in the hospital, give them bypass surgery, but it is something to consider, especially for women, because it is a very important disease for women of any age,
And I
not
think-
just elderly women.
Yes, and I think I would add one thing. If my birthday story reminds anyone that around the time of your birthday, remember to make an appointment to go see your doctor. And then you'll always remember every year.
right. Okay. So any other advice, Dr. Keller, about?
Well, the one thing that I'd like to point on is some of the problems that Michele did have with the constant stenting that she had to go through.
Yeah.
So part of the research that's being done at Albany Medical College is looking at restenosis, looking at the lining of your blood vessels, the endothelial cells, and how they might contribute to plaque formation, clogging of the arteries. And we're really trying to go to the forefront to try to understand how we can inhibit that, how can we treat those symptoms and the clogging of the arteries that happens. And so along with the American Heart Association, there's a lot of research being done to try to understand the mechanisms so that people like Michele don't have to go through 9 episodes of stenting. Every time you have an invasive procedure, you have a risk for complications to that procedure.
Right.
So if we can narrow that down where one stent will do you and will prevent restenosis or prevent the arteries from closing up, then that's the type of research that we really want to fund, and that's the research that's coming out of Albany Med, as well as other universities around the country. So it's very important to understand, and as Michele talked about her aortic valve. So when we have leakiness in our valves, it means that the blood stays in our heart, doesn't
Right.
flow through our bodies. And so it's important that we understand how these valves collapse, how they are dysfunctional, and how we can repair them. The mechanical valves have been great. They've saved so many people's lives for both the aortic valve as well as the mitral valve.
Right.
but it's important that we understand how that happens so that hopefully we can prevent, hopefully we can diagnose that earlier so we can treat before having to go and do surgical procedures. Along with having valve replacement, again, stenosis can still happen around those valves. So the tissue can grow within those valves and cause them to narrow.
Right.
And so, again, with the research that's being done, we can try to prevent that stenosis from happening.
So hopefully you are able to not only add to the research end, of course you're adding to the research end, but also the advocacy. And those two are essential.
That is correct.
To making people better, especially with the aging population. I would imagine that this is really going to be more of an issue years down the road.
That is very
and
true.
probably already is more of an issue now than it was in the past. I think we should give the American Heart Association some kudos here for what they do.
Definitely.
In contributing towards research.
Without their funding, my research wouldn't be where it is today.
Right.
I was lucky enough, the American Heart Association was my first funding that I received in my academic career. So I am very indebted to the funding that they gave. As well, the American Heart Association funds pre-doctoral and postdoctoral fellows. So these are students who are learning about techniques, and learning about heart disease, learning about other disease states. And the American Heart Association is really at the forefront of helping us train researchers to go out there to have a future, to decrease the amount of heart disease that's out there, to be able to treat it better. And these young people are our future for being heart healthy.
Well, I have to thank you two for coming today. Michele, you're lovely.
Thank you so much.
And good luck with your spokesperson duties.
Thank you.
And good luck in your future. Hopefully you won't have any more medical issues. I'll cross my fingers.
Thank you.
Dr. Keller, thank you very much for coming.
Thank you for having me.
And good luck with your research and advocacy as well.
Thank you very much.
Thanks for watching. We hope to see you next time on Focus on Health.